Hi, I'm Dr. Jared Gardner. Thank you so much for having me speak with you today about sarcoma classification. I am a dermatopathologist and bone and soft tissue or sarcoma pathologist, and I spend a lot of time thinking about these tumors. My goal today is not to teach you how to make the diagnosis of sarcomas, but how to better understand what these tumors are and how we as pathologists think about them from a subclassification and naming point of view. So, in the hopes that you'll better understand this very unusual group of rare tumors. These are my disclosures. I don't think any of them are relevant to the talk today, but out of full disclosure, I like to always display all of them. You can see more at this link right here. And these are my three daughters who maybe will grow up to be pathologists one day. And if you find the content interesting in this talk today and you want to learn more about pathology, I have a whole bunch of videos and also digital slides that you can actually explore and look at yourself. And these links here, they're all organized by entity name. So if you're ever wondering, what does a chondrosarcoma look like? Just go to the bone and soft tissue pathology link there, and you can check it out and learn all about it. So before we talk about sarcomas, let me talk about pathologists. A lot of people don't really understand who we are or what we do. So I want to make sure that all of you are familiar with our role in patient care. So we are medical doctors, actually. Every once in a while, people are not sure about that, but we are. We go to med school like every other doctor, either MDs or DOs. And then after medical school, we specialize in pathologists, just like some doctors specialize in surgery or OB/GYN or family medicine. Our main job, at least for many pathologists, surgical pathologists that is that we diagnose cancer and other diseases by examining tissue samples under the microscope. Of course, there are lots of different types of pathologists, some of whom never look in microscopes and run the blood bank or do other parts of medicine. And we oversee the laboratory to ensure accuracy and patient safety. So how do we actually diagnose tumors, cancer and other tumors? Well, the first thing is that a surgeon or another doctor has to take a tissue sample for us, either a biopsy or an excision, and they send it to the lab. And a lot of times I think patients are a little confused and think that the lab is some black box where you put in a little piece of tissue and an answer comes out on a computer screen and says, this is the kind of cancer it is, or nope, not cancer. But it actually doesn't work that way at all. There's a ton of people, not just pathologists, but really skilled laboratory technologists like histotechnologists and pathologist assistants who prepare the tissue, put it through a series of chemicals, cut it really, really thin into little thin 4-micron slices, and they put it onto glass slides. So there's a whole team of very skilled people in the laboratory and a lot of manual steps that it takes to go from a tissue biopsy to a final prepared stained slide that's under my microscope that I then have to look at and decide, is this cancer or not? And if it is cancer, what kind is it? But I have a whole team of wonderful people in my lab without whom I definitely could not do my job. So we take that thin slice of the fixed processed tissue and we put it on a piece of glass, and then it gets dipped in a series of chemicals that will stain it and allow us to see the cells, which normally would look clear or whitish under the microscope. It allows us to add some color to them so that we can tell apart the different parts of the cell. So that stain is called hematoxylin and eosin, which we abbreviate as H&E. That stain has been around for over 100 years, and it's still more or less, with some slight tweaks, it's still more or less the same way it was done 100 years ago. Although we have some machines that automate it now, we're still doing pathology, the basics of pathology, the same way it was done a century ago. It's really amazing, actually. So the next step is that I then look under the microscope, or whatever pathologist is looking at it. We look under the microscope and decide based on the appearance of the cells, or what we call cytology, and also how the cells are arranged, what their relationship is to one another. That's the architecture of the cells. And putting those features together and comparing it or contrasting it against what normal tissue should look like, we decide if it's abnormal. If it's abnormal, is it a neoplasm or a tumor? And if it's a tumor, is it cancerous or is it benign? And then basically, like I said, that H&E stain of a tissue section plus a regular light microscope, those two things together is basically the bedrock foundation of what we do in pathology for tissue diagnosis pathology. And taking that microscopic findings and my knowledge of what that looks like compared to normal, plus the clinical information, how old is the patient, how big is the mass, where is it on their body, we can put that together, and in most cases we can use those things to make the diagnosis. Now, some cases are hard, and sarcomas and soft tissue, bone and soft tissue tumors tend to be more often in that hard and difficult group. So in those cases, we may have to use some extra ancillary testings in addition to looking at the tissue under the microscope. And those extra things can help us confirm the diagnosis and also exclude other potential mimics. Sometimes things can look alike microscopically, but be very, very different in the way that they're treated or the way that they behave. So if you're curious more and want to see some actual examples of what this stuff looks like in the lab, I've got a little video that walks you through the lab and kind of follows a biopsy from when it comes to the lab all the way until it's made into a slide. You can see that on my YouTube channel. Just Google Jared Gardner YouTube and it should pop right up. So one of the main ancillary tests we use is immunohistochemistry or immunostains. These are basically antibodies that we take a little thin slice of tissue, and instead of dipping them in the normal H&E stain, we add these antibodies, and through a series of steps we add some color to the antibodies, and whatever the antibodies will target and stick to a specific type of protein. And we have lots of different antibodies for looking for lots of different proteins. And those proteins are also known as antigens. And then we can see which cells have the antibodies stuck to them because they'll turn this brown color, okay? Or sometimes red. It depends on how your immunostain is set up. And so seeing, if I see tumor cells, based on which stains they're positive for and which ones they're negative for, I can sort out what kind of tumor cells they are, what tissue type they resemble. Are they muscle cells? Are they neural cells? Are they melanocytes or something like that? And so sometimes we can look at tumors and tell just by their visual appearance, but other times, particularly when tumors become very ugly and nasty looking, they don't resemble normal anymore, and we have to use immunostains to identify what their origin is. So a lot of times we use the immunostains not to tell us if something's cancer or not, but to tell us what type of cancer or what type of tumor something is. Now, sometimes we do use stains to help us confirm cancer, but much of the time our stains are actually helping us to figure out what type of cells we're looking at when it's not obvious. So here's an example of alveolar rhabdomyosarcoma, which is a sarcoma, a malignant tumor of skeletal muscle. But these little round blue cells here don't look anything like normal skeletal muscle looks like under the microscope. So the way that we tell that they're actually muscle cells is that they express muscle proteins or antigens. And in this case, that protein is desmin. And so the antibodies here that are colored brown are sticking to these cells because these cells are filled up with desmin protein. So we can use these as a clue to help us figure out the cell type. And you can see the background tissue is negative. Sometimes we use molecular testing, and this is a complicated and also rapidly evolving area of pathology that's really revolutionizing a lot of the things that we do, and will continue to do so, I think, more and more in the future. And there's lots of different types. Some of the most common ones are FISH, also known as fluorescent in situ hybridization. That's why we call it FISH. And RT-PCR and newer things like next-gen sequencing. And so a lot of sarcomas will have gene abnormalities, DNA, molecular abnormalities, and detecting those can help us not only with diagnosis, but also sometimes can give us prognosis information about which tumors are more likely to behave in an aggressive manner or respond to certain treatments, things like that. So now finally, what is a sarcoma? So sarcomas basically are rare cancers that arise from mesenchymal cells. That is the cells that make up the connective tissues in your body. If you think about it, if you take away all the lining cells like the skin or the inside lining of your gastrointestinal tract, those are epithelial cells. Most of the functional component of your internal organs are epithelial cells. And cancers of epithelial cells, as we'll talk about here, those are called carcinomas. Those are much more common tumors. If you know someone who's had cancer, or if you've had cancer, statistically speaking, it's much more likely that you've had a carcinoma or that you have a friend or family member who's had carcinoma rather than sarcoma. So if you take away all the epithelial cells from the body, much of what's left, the parts that are in the soft tissue and the bone that hold everything together, those are the connective tissues. And the sarcomas that arise from those types of cells cancers that arise from those types of cells are called sarcoma. So malignant connective tissue type of cells, or mesenchymal cells is the technical word we use for it. They usually arise in the deep soft tissue, not surprisingly, because that's where those connective tissue cells are most common, but there's exceptions. They can really arise in a lot of different sites, including the skin and sometimes even the organs. And there are many different types of sarcoma, and most of them are very different from one another, despite sometimes having similar names. We'll touch on that later. And like I said, carcinomas are so much more common than sarcomas. And again, if you think of breast, lung, pancreas, prostate, colon, most of the cancers, the organ cancers that you've heard of, most types of skin cancer that you may hear of, those are almost always carcinoma. The vast majority are. And sarcomas are cancer, but they are very different and unique types of cancer compared to most carcinomas. So the behavior and the specific way of the specific types of treatment that are used for sarcoma is often very different from carcinoma. So it's a really unique group of tumors and often requires the patient to be managed and cared for by a specialized team that has experience in dealing with sarcomas, because they are so rare that most doctors do not encounter these in their practice unless they specialize in sarcoma. There are many doctors who will never see even one sarcoma in their entire career. So the standard naming format for how we divide up not just sarcomas, but even benign bone and soft tissue tumors, it goes like this, okay? The tumor cell type. What type of normal tissue does the tumor cell resemble or arise from? And then we add on the ending oma, the suffix oma, if it's a benign tumor, or sarcoma as the suffix if it's a malignant tumor, okay? So leiomyoma means smooth muscle, and oma means benign tumor, so leiomyoma is a benign smooth muscle tumor. In contrast, a leiomyosarcoma is a malignant smooth muscle tumor. Lipoma, benign fatty tumor. Liposarcoma is malignant fatty tumor. And the same for osteoma versus osteosarcoma, or chondroma versus chondrosarcoma. I think you get the picture. This is the general way that we name bone and soft tissue tumors. Then we go a step beyond that, and we often will add various adjectives onto the name. And those adjectives can be there to indicate a specific type or a unique subtype of that particular tumor, or also to give information about the differentiation, or basically the grade of the tumor. An example here is liposarcoma. We have well-differentiated liposarcoma, dedifferentiated liposarcoma, pleomorphic liposarcoma, and myxoid liposarcoma. So D-diff liposarcoma is like the high-grade form of well-diff liposarcoma. They're related, but they're different in their prognosis and the behavior, because the D-diff is a higher-grade version of well-diff. But pleomorphic liposarcoma, totally unrelated. Yes, it's a fatty tumor and it's malignant, but basically that's where it ends. It's much more aggressive, behaves very differently. It arises in different parts of the body than well-diff and D-diff liposarcoma usually do. So it's a very different tumor despite just a slight change in the name. Same with myxoid liposarcoma. It arises in young people, has a very unique behavior that's very different than these, totally unrelated, and it looks totally different microscopically. So you can see these slight changes in name can make a very big difference in what the tumor actually is and how it's treated and how it behaves. So what is differentiation? I've mentioned it a few times, and I think it's something that's not always explained to people at first. We get used to using the term, but what does it actually mean? So differentiation is how closely does any type of cancer resemble its corresponding normal tissue or cell type, the type of tissue that it basically arose from. Now, we always talk about things arising from certain normal tissues, and that's not exactly probably how it happens at a biological level. It's actually probably some precursor stem cell, and then the tumor cells begin to grow and resemble normal. But in any case, that's a much more complicated topic. For practical purposes, you can think of many types of cancer arise from or resemble a normal tissue type in the body. So when we say the word well differentiated, it means that the tumor cells, even though they're malignant, they look very similar to the normal tissue. Usually you can look at it and recognize, oh, those cells look like smooth muscle, or those cells look like fatty cells, adipocytes, okay? And those tumors are usually grade 1, low-grade tumors. Then at the other end of the spectrum, we have poorly differentiated. And as you can imagine, that means that the tumor cells are so ugly and nasty that they don't really resemble the normal tissue type much, or even sometimes at all. Sometimes they look a little bit like it. Other times they don't look anything like normal tissue. And the only way we can tell that they're related is by using immunostains to identify the different proteins in those cells that are a similar pattern to the normal tissue, okay? And poorly differentiated tumors are grade 3 or high grade pretty much always. And in other types of tumor like carcinoma, we sometimes use the term moderately differentiated, but we don't really use that language with sarcomas. I'm not exactly sure why. And then also there's dedifferentiated, and that's a little bit more weird and confusing. It's also grade 3 or high grade, but this tumor has no resemblance to the normal tissue at all. And oftentimes, even if we do stains, it doesn't stain like the normal tissue. The only way we really know that it is what type of tissue it is because we see that there was a low-grade, well-differentiated sarcoma there, and then that tumor became high-grade. It dedifferentiated and it lost its normalness. It lost any resemblance to the normal tissue and became a high-grade, ugly sarcoma that doesn't look like any normal tissue type. So that's called dedifferentiation. And those tumors are usually bad, high-grade tumors. So let me show you an example here. Normal adipose tissue is made of mature fat cells. That's what these big white circles are here. They're normally in our body filled with lipid or fat material, but when we process the tissue in the lab, all of that fat and lipid inside dissolves and it just leaves this little thin cell membrane around the outside of each cell. So each one of these big white circles or squares, whatever shape you like, is a benign mature fat cell. This is from someone's normal subcutis. And you see a little blood vessel over here. There's a little red blood cells there. This is collagen, fibrous tissue. That's a normal thing that exists around the fatty structures in the subcutis. So now if we look here, this is actually a type of cancer, a sarcoma, well-differentiated liposarcoma. And you can see this is a big, ugly, abnormal, pleomorphic cell. By ugly, we mean very large and very dark, very atypical compared to normal. But all of these cells here look very similar to the fat that I just showed you, but they're not normal. These are mature adipose cells, but they are actually part of the tumor. All of the cells here pretty much are malignant tumor cells. They're all well-differentiated liposarcoma. And if I didn't have this ugly atypical cell and I just had this fat, I wouldn't microscopically be able to tell that apart from normal tissue. It looks so much like it. So that's why we say it's well differentiated. This tumor really closely resembles normal fat, but it's actually a low-grade malignancy. Now, in contrast, this is a very high-grade, very atypical tumor. It's got very huge atypical pleomorphic cells. These are the nucleus of the cell, and this nucleus is like 15, 20, 30 times bigger than some of its neighboring tumor cell nuclei. So this wide range in the size and shape of the nuclei is usually a bad sign with tumors, okay? But look, there are some clear bubbles that were filled with lipid, and so cells that have a lot of these bubbles are called lipoblasts, and some of the cells here almost resemble those mature fat cells, but the vast majority of the cells here do not look anything like the normal fat I just showed you. So this is a high-grade tumor. It's poorly differentiated, and the name of this poorly differentiated tumor is called pleomorphic liposarcoma. That's its proper name. Now, what about this? This is also a liposarcoma, but it doesn't look anything like fat. There's no bubbles or vacuoles, no lipoblasts, nothing. The only way that we can know that this is actually a high-grade malignancy, a high-grade sarcoma of fat or a liposarcoma is because elsewhere in the tumor, we can see it's the ugly areas that look like high-grade sarcoma are here, but here's another piece that was sampled from elsewhere in a large tumor mass, and at high power, that is well-differentiated liposarcoma. So it's a well-differentiated liposarcoma that has kind of turned bad, even worse, and it's become dedifferentiated and lost any of its normal fatty look and has become a very high-grade tumor. So that's what we mean when we say dedifferentiated. Now, let's talk about some exceptions to the naming rules. So one is sometimes we use the term malignant blank blank tumor to mean a certain type of sarcoma. And here's some of the notable ones that come to mind when I think about that. Malignant peripheral nerve sheath tumor, or MPNST. It's a type of sarcoma, actually, that is a nerve sarcoma. So malignant peripheral nerve sheath tumor is actually a sarcoma, even though it doesn't have the word sarcoma anywhere in its name. Malignant glomus tumor, and there's also malignant solitary fibrous tumor, and there are some others like this. So sometimes malignant added on to the name of a tumor can mean it's a sarcoma even though the word sarcoma is not in the tumor name. And I realize that's confusing. And I'm just adding some pictures here so you have something to look at if you get bored while I'm giving the rest of this lecture. So that is a malignant peripheral nerve sheath tumor right there. Sometimes the tumor name is actually totally unrelated to the tissue of origin. I taught you earlier about the classic names, which are that the name is telling us what type of tissue or the tumor cells resemble. But there's a lot of sarcomas that actually don't resemble any normal tissue or cell type. They don't have any corresponding normal tissue. We don't know what cell they arise from. They probably come from some sort of immature, primitive precursor cell, and they become their own special type of cell that is not like any other normal cell in the body, okay? And so the way to name these is often based on their microscopic appearance or is based on some historical things where people named them something a long time ago and we never came up with a better name, so we continue to use the old historical name. Or sometimes we use a person's name, like Ewing sarcoma or Kaposi sarcoma. named after the people who helped discover them. So the examples are epithelioid sarcoma, clear cell sarcoma, Ewing's and Kaposi sarcoma. Synovial sarcoma is one I really like to point out because the name would suggest that it is growing from synovial cells, the kind of cells that line your knee joint and all of the other joint spaces in your body. But actually, no, these tumors have nothing to do with synovial cells. I think long ago, many, many decades ago, people suspected they might, but now we know that there's nothing at all related between them. These tumors don't have to arise near a joint or near the synovium, and they are not arising from synovial cells. So the name is kind of a misnomer. It's confusing there. And this is an example of synovial sarcoma right here. Now, sometimes the tumor name is actually based on a specific defining molecular abnormality. And like I said, a lot of sarcomas have gene abnormalities, particularly gene fusions or translocations. That's when two different genes break apart and split, and then they hook up with each other. Half of one gene fuses to half of another, and that makes a brand new type of protein that then drives the tumor to grow. And sarcomas particularly, there are lots of sarcomas and other benign soft tissue tumors too that have gene fusions. And it's a very, very common type of abnormality in soft tissue tumors, and the list of these is growing constantly. There are like new ones reported all the time. And that list will continue to grow as we test more and more tumors in the future molecularly. And some sarcomas are actually, we only make the diagnosis based on the molecular abnormality. And so sometimes they are named based on the molecular finding because that's the defining characteristic that lets us make the diagnosis. Finally, I want to also bring up that there's an unusual and frustrating group of tumors. Thankfully, not too many of these, but they are an intermediate category of tumors. By intermediate, we mean not intermediate grade or grade 2. We don't mean that. We mean they're somewhere between benign and malignant. They're not quite benign and they're not quite malignant. And that's not very satisfying. That's scary because, patients and other people want to be told, is it cancer or not cancer? And there's sometimes that we have to say, particularly in soft tissue pathology, well, it kind of depends. And these tumors are hard to explain and hard to wrap our minds around even as doctors. So these tumors usually are either locally aggressive, they have a high tendency to grow back locally, sometimes multiple times, and or they can rarely metastasize, but usually not. So it kind of calls into question, how do we decide what to call cancer or malignant versus not? And that's actually a much more complicated question that's way outside the scope of this talk. But in any case, there are these tumors that either locally aggressive or rarely metastasizing that we will say go in this intermediate category or the kind of gray zone between benign and malignant. And a couple examples are desmoid fibromatosis, which does not metastasize but can be locally aggressive and really morbid and symptom producing for the patients, and also angiomatoid fibrohistiocytoma, plexiform fibrohistiocytic tumor. These are very rare tumors that you may never encounter in your whole practice, but they are things that in general don't metastasize, but occasionally they do. So here's an example of an angiomatoid fibrohistiocytoma. So you might be wondering by now, who names all these tumors? They're so confusing, and it's true. Particularly, there are certain words that we tend to reuse in tumor names that sound very, very similar, and yet the tumors are totally unrelated. And perhaps the worst kind of trio of these is myxofibrosarcoma, myxoinflammatory fibroblastic sarcoma, and low-grade fibromyxoid sarcoma. If you are frustrated and shaking your head in disgust right now, you're not alone because this is very confusing even for pathologists. I have to explain this to people regularly because these are all relatively rare tumors. As I said, all sarcomas pretty much are rare, and they have very, very similar sounding names. So this is a very big frustration. The reason I'm bringing it up to you is so that if you encounter one of these names, make sure you go back and double check to be totally certain that that's what the name is before doing anything with that information. Just make sure that the name is verbatim and that you've checked the actual pathology report to see that that's what it is, because sometimes these sound similar and they may get confused and swapped and mixed up when they get copied into a clinic note, and you know how the game of telephone works, things can get very scrambled along the way. And so the reason I want to bring this up is, as frustrating as it is, again, this is the way it is currently, these are the way the tumor names are, we just have to work with what we've got right now. Minor wording changes that might not seem very significant grammatically, but those minor changes can make a huge, enormous difference in the meaning of what the tumor is and what it will do or how it gets treated or how it will behave. So when you're recording things or putting things into a tumor registry or into a clinic note, make totally certain that you get the actual diagnosis right. I actually like to, when I'm copying a diagnosis and putting it into one of my pathology reports and I'm saying, oh, a previous biopsy showed this, I like to put quotes around the exact words that the pathologist used in their final diagnosis line, and then I'll usually put a reference number, hey, go see this report to get more information. That way, anyone who reads it in the future can go look back and get all the details and avoid getting confused because I might have typed something wrong. So I like to do it that way. And then sometimes the word sarcoma is used in the name of a tumor when it's not actually really a sarcoma at all. One of the worst examples of this, the one that I really particularly hate, is myeloid sarcoma. And this is basically a term for leukemia when it forms a mass in the skin or the soft tissue. And it's an old-timey term that still persists for some reason. And I find it very confusing for most people. When they hear this, it does not mean they have sarcoma. It means they have leukemia that's forming a mass, okay? And then the other time is sarcomatoid carcinoma, or the closely related entity carcinosarcoma. These are basically there's a little debate over this, but the way I think of them is they are high-grade, poorly differentiated carcinomas, epithelial tumor malignancies that have become so high-grade that they have kind of started to de-differentiate and begin to look like malignant spindle cell tumors, or they begin to look like a sarcoma. Okay, so here's an example down here of a carcinosarcoma. This is squamous cell carcinoma right here, these big pink cells, and they transition into these sheets of malignant spindle cells that look very similar to sarcoma, but because they're arising from a obvious carcinoma, we know that this is not really a sarcoma here. This is just a carcinoma that has become so ugly and high grade that it begins to microscopically resemble sarcoma. So those are two times you might see sarcoma in the name of a tumor, but it's not actually a sarcoma. So finally, what data points actually matter most for sarcoma? Well, I want to say the tumor name, I think I've harped on it enough, is really, really important. The exact specific name with all the adjectives is oftentimes the very most important data point in determining how a tumor will behave and how it's going to get treated. Because specific types of sarcoma behave very differently. Then after that, I would say the grade. Is it high grade or low grade, or grade 1, 2, 3? There's different systems that can be used. Mitoses and necrosis are important, but really they're incorporated into the grade. Some sarcomas by definition are high grade, regardless of what features they show. Some sarcomas we don't really apply a grade to because grade doesn't help us really predict how they'll behave. And other things like size and depth and site are certainly important, but I would say that most of the time they're less important than these 2 points here. There may be some people who would disagree with me on that, but I really think these are the very, very important features here, and it's really important to not mess those up. And also molecular info, if it's in the report, if you're filling out a cancer registry, if you see molecular information like translocation or FISH results in a report, if there's a place to include that in a registry, that's often very important both for diagnosis and prognosis. Now, I'm just going to skip over these because we're out of time, but I just wanted to let you know I put together a list here for you so that you can come back and reference this from the handout later. These are the major categories of how we divide up bone and soft tissue tumors based on the 2020 WHO Bone and Soft Tissue Tumor book, which is like really the gold standard for most of us in soft tissue and bone pathology. And I've left out some complicated things to save space. But basically, this is how we divide things up, and it includes adipocytic or fatty tumors, and here's benign on the left, or some intermediate grade. I've put those both on the left side, and then malignant ones on the right side. And I've done the same with fibroblastic and myofibroblastic, which, as you can see, is a huge list of tumors. Smooth muscle and pericyte tumors, skeletal muscle tumors, the malignant ones of which are rhabdomyosarcoma, and each of these are totally different tumors, very different in every way. So very important to make sure that that adjective is crucial in telling those apart. Vascular tumors like angiosarcoma and epithelioid hemangioendothelioma on the malignant side, and some benign things over here, hemangiomas. And nerve sheath tumors, both malignant ones and benign ones. Bone tumors, osteosarcoma being the main example of a malignant bone cell tumor, and chondrosarcoma is the main example of a malignant cartilage tumor. And then there are some other undifferentiated round cell tumors like Ewing sarcoma, and then a whole list of tumors, both benign and malignant, that we don't really know what cell they come from. They don't resemble any normal cell. And this is, like I said, a complicated kind of wastebasket of different diseases here. But I wanted to put all these here so that you can reference them if you encounter these terms. Hopefully this will help you to sort them out. And I know that was a whirlwind through a very complicated thing, but I hope it gives you some insight into how we as sarcoma pathologists think about and name and subclassify bone and soft tissue malignancies. Thanks so much for the great work that you do for patients, and thanks for listening.